Welcome to Lab Talk, the podcast where we break down the science behind clinical laboratory testing and actually make it interesting. Today we're discussing von Willebrand factor. It shows up on your coag panels, your mixing studies, your factor assays. But what is it, and why is it so important? Whether you're a seasoned lab professional, a student, or just a curious mind, this episode is for you. Let's get started. Von Willebrand factor, or VWF, is a large multimeric glycoprotein synthesized in endothelial cells and megakaryocytes. It gets stored in Willebrand bodies in the endothelium and in alpha granules and platelets, and it is released when there's vascular injury. Von Willebrand factor has two main jobs: bridging platelets to exposed subendothelial collagen at the site of injury, and acting as a carrier protein for factor VIII and protecting it from premature degradation in circulation. Interestingly, VWF circulates as a range of multimer sizes. The ultra-large multimers are the most hemostatically active. ADAM-TS13, a protease that cleaves VWF, is what keeps those multimers from getting too large and causing unwanted platelet aggregation. That balance between VWF release and ADAM-TS13 cleavage is central to understanding both von Willebrand disease and thrombotic thrombocytopenia purpura, or TTP. Von Willebrand disease, or VWD, is the most common inherited bleeding disorder. When a patient comes through with easy bruising, prolonged mucocutaneous bleeding, or heavy menstrual bleeding, VWD is on the differential. There are three main types, and knowing them matters to how results are interpreted. Type 1 is a quantitative deficiency. Not enough von Willebrand factor, but what is there functions normally. These patients usually have VWF antigen and activity that are proportionately reduced. Type 2 is where it gets interesting. Type 2 is qualitative. The quantity may be near normal, but the protein doesn't work right. And type 2 has various subtypes that are distinguished by the specific dysfunction. Type 3, the most severe, is identified by near-absent von Willebrand factor levels, very low factor VIII levels, and significant bleeding risk. Laboratory diagnosis and subtyping of von Willebrand disease often requires a panel of tests. Testing may include VWF antigen, which measures the quantity of protein, regardless of function. Antigen results will be low in type 1 and type 3, but may be normal or near normal in type 2. VWF activity is classically measured by ristocetin cofactor assay. This test uses ristocetin to facilitate binding of von Willebrand factor to GP1b on donor platelets. However, results of this assay are prone to interlaboratory variability, as well as highly dependent on the quality and concentration of the donor platelets. In response, the International Society on Thrombosis and Hemostasis now recommends GP1b-based assays as the preferred method for VWF activity measurement. These assays use recombinant GP1b fragments that are engineered to bind VWF without the need for ristocetin or donor platelets. Many laboratories have transitioned to GP1b-based methodologies, which may yield better reproducibility and less variability. Factor VIII activity may be included in testing to help identify type 3 and type 2N, one of the type 2 subtypes that is associated with low factor VIII. And finally, a multimer analysis may need to be performed. This test is typically a gel electrophoresis-based method that can tell you if the high molecular weight multimers of VWF are present. The ratio of VWF activity to VWF antigen is useful. A ratio below 0.6-0.7 suggests a qualitative defect. You're likely looking at a type 2 variant, not type 1. When interpreting results, there's one other thing to note. Blood type matters. Blood group O individuals have VWF levels roughly 25% lower than non-O individuals. That's not disease, that's biology. Reference ranges ideally should be type-specific, and you should be aware of this when reviewing borderline results. Once testing is completed, interpreting those results is not necessarily cut and dried. First, von Willebrand disease can be acquired in certain conditions, and once those conditions are resolved, testing may revert back to normal. On the flip side, VWF is an acute phase reactant and may be elevated in inflammation, surgery, or pregnancy. So a normal or high result doesn't rule out VWD if the patient was acutely ill or pregnant at the time of collection. For these reasons, von Willebrand testing should be repeated a few months apart to minimize the influence of acute illness on the diagnosis of VWD. Let's wrap this up. VWF sits at the intersection of platelet function, coagulation, and endothelial biology, which is probably why it's so diagnostically rich and occasionally maddening. Know your panel, know your subtypes, and remember that blood type and clinical context are part of the result interpretation, not just the numbers. Well, that's it for today's episode of Lab Talk. If you enjoyed this episode, make sure to subscribe, leave a review, and share it with your fellow lab professionals. If you have a question or a topic you'd love for me to cover next, shoot me a message and let's keep the conversation going.